Hi, my name is Adele Brown and I'm a physiotherapist working in gerontology. I'm presenting the findings from our work titled Determinants of Bladder Care at Night on an Aged Care Hospital Ward. I would like to thank my colleagues Laura Ferguson, Michael Whishaw and Wendy Bauer for their contributions to the background of this research and the implementation of this study. The majority of elderly patients do not toilet independently during the day or night when in hospital. I'm sure people think that the answer to this question may be because of mobility limitations while in hospital. However, that may not be the case, and there may be additional barriers that influence the type of assistance and support patients receive for their bladder care at night. Overnight, toileting in aged care wards may be seen as a solely nursing responsibility. At night time, when staffing ratios are low, a patient's urgent request to use the toilet can become a falls risk activity. The background for this study was from recent work that established in our hospital that 34% of all inpatient hospital falls were related to toileting, with most of these falls at night time occurring in patients who did not mobilise with their recommended level of staff assistance. Although falls risk assessments are implemented in hospital wards to prevent falls, it means that patients are often reliant on staff to assist them to the toilet. On the other hand, due to this perceived falls risk, patients may be toileted in a method that is not to their preference or appropriate for their level of function. Given that mobility and continence are both known to impact discharge destination, the independent ability of a patient to manage their nighttime bladder care has significant implications to our patients when they are in hospital. With this background information, our aim was to evaluate how bladder care at night aligns with a patient's mobility status during their admission on an aged care hospital ward. The specific objectives that are linked to the study are described on the right-hand side. We conducted an observational study to quantify the care units related to nocturnal bladder management and used a convenience sample of 63 aged care rehabilitation patients over 3 consecutive nights. Variables we collected included documented type and timing of toileting and/or bladder care, measurement of patient comorbidities, mobility classification for bed, transfers, ambulation, ambulation distance and use of a gait aid. The type of bladder care was recorded by staff each hour, with coding for discrete units, as seen on the right-hand side of the slide. The mean age of the participants was 82, and the cohort was evenly split by sex. Some form of equipment to support mobilisation was used by 82% of our patients, with less than 1/4 being independent. Overall, 27% of our patients required assistance to move in bed. 41 required assistance to sit up from bed, and 48% of patients required assistance to stand from a seated position at their bedside. These characteristics highlight a low-functioning cohort who were frail and vulnerable. This suggests that they were at risk of a change in discharge destination post their hospital stay. Over the 3 nights, the average number of care episodes to address bladder function ranged from 0 to 9. Most were woken on average twice a night, and assistance to empty bladder was provided on 254 occasions, with only 9 patients able to self-toilet during the night, although 17 were classified as independent with ambulation. This highlights the poor sleep quality of an elderly frail cohort during what is their rehabilitation admission, and how frequently these patients are awake during the night for the management of their lower urinary tract symptoms. We found that mobility in bed and the support required for ambulation, rather than age or walking distance, influence bladder care management at night, and that the number of bladder care units that a patient received was not associated with ambulation distance or age. Our findings suggest that it is more than nursing staff who may influence bladder care, and asks us to consider who really is responsible for bladder care at night. While no one person is responsible for bladder management, the entire multidisciplinary team could be responsible for improving bladder function at night in the elderly patient, as demonstrated by this slide. Although we found that there are factors that may limit ability to be independent and safe with bladder care, if there was an expectation of improving bladder care and optimising independence that came from all members of the team, we could implement changes during the day and at night to support and improve independence, preference, and safety with nocturnal bladder care. To summarise this presentation, we met the objectives and showed the following key practice points: that multiple awakenings and disrupted sleep are common at night in hospital. Mobility in bed and support required for ambulation rather than age or walking distance influences bladder care practices at night. That therapy to improve independent movement in bed and transfer practice at bedside may reduce the need for overnight incontinence care. We found that improving bladder symptoms at night requires input from a multidisciplinary team and expansion of practice by all clinicians. Given that both mobility and continence are known to impact discharge destination from hospital, a multidisciplinary approach to overnight bladder care is needed in the aged care rehabilitation setting. Thank you.